Okay, Dr. Alvear.
Okay. My main goal for now is to try to find surgeons who are willing to learn the procedure. It seems to be the only procedure that works well. I mean, I don't care what other people are doing, but from 1978 to the present, the procedure that I conceived or learned from somewhere, I don't know, I learned it myself, seemed to be the one that worked. When I first started the procedure, the concept was, how do we fix this? Because supposedly, according to the diagram, you have aorta and you have the small superior mesenteric artery, and you're supposed to be pinched like a pinch. The duodenum is being pinched by it. And I said, that doesn't look right because you have a mesentery. So when you look inside, it's not like the diagram shows in the journals or the book or anything. It's really different. So people are confused. I got confused. I was confused myself. So I decided that what is the embryology of the intestine, the stomach, the duodenum, and the small intestine? What happens in utero? And in utero, what happens is we develop these things the first trimester of pregnancy and the first few weeks of life, like 3 weeks, the stomach, the intestine develops, and then you have the intestine has to rotate a certain way, 180 degrees, then 360 degrees. So in effect, after the complete rotation, what will happen is the duodenum will then pass underneath the superior mesenteric artery, and then the jejunum will go around in a circle, and then the large intestine will have to rotate around, and that the cecum and the appendix will be in the right lower quadrant. That's why your appendix end up in the right lower quadrant. So if you have a problem with what we call a malrotation, which is the rotation incomplete, or we call we also call a non-rotation, which is also it didn't rotate properly or it stopped somewhere. So then your appendix or your cecum is in the wrong place. And the problem with that is when that happens, you can have symptoms. Some people can have a malrotation or non-rotation for all their lives. Nothing happens until something happens, like it can twist, and then you can lose your entire small intestine and the right side of the colon when that happens. So anyway, so basing on that, because I'm a pediatric surgeon, I've dealt with malrotation in children and babies and older kids, and even teenagers who had never had a symptom, and then suddenly they have a problem. I dealt with that. So then I came with this superior mesenteric artery compression syndrome, which I call compression because basically the pain that you have is probably partly obstruction and probably we call it transient ischemia, meaning because the artery is pounding. Like that's why you call it postprandial pain, because it happens after you eat something, or you think of food. When you think of food, we've known that from experiments in the dogs and early on, that when you think of food, as if you're like eating, even if you just think about it. Just think about food and you put it in your mind, and then you think of delicious food. So what happens then, when you think of food, your stomach start churning, and then your arteries start bonding. So then it start bonding against the duodenum. And to me, I haven't proven it, because I don't have time to experiment anymore. But I haven't proven it. But I believe it's what we call a transient ischemia, which is like if you squeeze on it like a vice, you squeeze on the organ like a vice. Of course, you create a transient ischemia, meaning there's something happened with the blood supply, microscopic blood supply, and the one that can give you worse pain anywhere besides a kidney stone can give you a severe pain. The one that gives you worse pain is ischemia. That's why when you have a heart attack, you have a bad pain, really bad. Some people don't have a pain with the heart attack because it's the wrong place. But in the correct place, you'll have a severe ischemic pain. When you have when there's a clot that went into your leg and cause ischemia, that's a severe pain. When you have a kid had a torsion of the testicle, twisted testicle, that's a severe pain. When a lady or a teenager or even a young female patient have a twisted ovary, that's a twisted, you have a ischemia of the ovary, and that's horrible pain that can be controlled by narcotic. So this is why you have the pain, I believe, in SMA compression syndrome, because of the bonding pain by the SMA after you eat or after you think of food. And I haven't proven that because I don't have time to experiment. But I'm sure some young person someday will be able to do that and prove it, to prove my theory. That's my theory. It's a theory on my part. So anyway, so the way I conceive this idea of derotation is that you go back to embryology, go back to the original, when the baby was still in the womb and trying to rotate the bowel. Why don't I reverse the whole thing? Reverse the rotation, including the duodenum, the small bowel, and colon, and everything. And that's how it started. I have no idea what to do. And I did that, and it seemed to work. And in the beginning, in my, I did 37 cases, by the way, from 1978 to 2016. And so I've been learning ever since. And what I learned is that when you derotate, you must do two things. You got to do two things in order to make it work, because some of the patients initially that I did not work. They were still having bile drainage for, oh my God, 2 weeks, 1 month later. And I said, what the heck is going on? I had to go back. And I found that even after you divide the ligament, so-called, that's another thing, another fallacy. The ligament of Treitz is not like the book. It's not the same for everybody. The so-called ligament of Treitz that everybody is talking about, the strong procedure, everything, that's not the way it is in actuality. I've seen so many of them that I say, this is not right. I gotta redraw the whole thing. I gotta figure out how to prove to the other surgeons that what they're believing is not right. And that's my difficulty. That's my difficulty right now. But anyway, we found a solution to the problem. But anyway, the ligament of Treitz is not the same as they show on the book. That's bunkers. I can tell you right now. Okay? But I have to prove it. That's another thing I have to prove. And it's my duty, but I don't have much time. You know, I'm 82 years old now. 82. So how many more years do I have? If I was younger, I'll have all the time in the world to prove it. So I find somebody who's willing to prove it. Anyway, that's another story. But anyway, so what I did, what I found, and now we're finding it now that we have done more since July 2024 to the current president, Dr. Folks had done over 40 cases. So I've seen different anatomy. And I've helped him in about maybe 15 cases. We have done reversals. We have done, all people have done failed strong procedures, failed failed D&J, failed everything. And we have reversed them. They're going to get better eventually. And then Dr. Stevenson's have also done the same thing. Stevenson in Austin, Texas, followed my recommendation, and is also starting to see some of the failed cases that is doing is correcting. So I'm very happy with that, because Dr. Stevenson, nice fellow, and he is following everything that I've told him. So he's a wonderful guy. He's going to do fine. Dr. Fowlkes is a wonderful guy. And Dr. Teron in South Africa, unfortunately, he didn't follow my recommendation. So he did something with another case and failed because he didn't follow my recommendation. So the people in Egypt, I went there and I tried to convince 40 surgeons that the procedure that I perform is the right one. No, they're bullheaded, and so they're still doing the D&J, so they're gonna fail. So unless I go back and prove to them that they're wrong, they'll continue to fail. So anyway, figure out that every case now, ever since we started in July of 2024, we found that every time after we divide the so-called ligament of trice, I call it so-called because it's not really the way it is in the book. We just cut it, and then we find that there's always a notch or something in that area that's not quite straight. Even if you do a so-called strong procedure, you cannot straighten that out. Especially if you don't stitch the area to the abdominal wall, it'll go right back. Because nature says, this is not my area, I'm going to go right back to where it was. That's why it fails. Everyone will fail. I can assure you, everyone will fail if they don't suture that. And even if they suture that, those patients will take a long time to recover, because there's something in the D&J junction that's not going straight. This is why we recommend the staple anastomosis in that site. Once you take it off the midline and you put a staple, one single staple, and you then divide that area, do a anastomosis, we call it physiologic anastomosis, between the fourth portion of the duodenum and the first portion of the jejunum. And if you do that, then you'll have an opening right away. And most patients can start eating sometimes 6 days later, like Brittany. Brittany Baylog start eating at 6 days and still eating even up to now. She has to still have to do frequent small feeding, but increasing her diet frequently. And some people will take maybe 2 weeks, depending on what they had before, but eventually they will eat. The patient that we did, first patient we did in Texas, 13-year-old, she's now eating normally. She was done, I think, 3 months ago, and she's now eating everything. 3 months later, the patient I did in Philippines in February of 2024, she's 17, and she's now eating normal, eating everything.
Oh.
The patient that was redone, that was previously done by Dr. Shawed and Dr. Stevenson did, revised through my recommendation, she's better. She's going to be better. She's going to be normal eventually. The people that we had revised got better. The people who are still on narcotics will have a long time to recover. So if you're not on narcotics for your pain, if you can decrease the amount that you use, and after the operation you try to get off completely, you're gonna get better. My best patient was an Amish girl that never had any medicine for her pain, and she got better right away. Within a week, she was eating. I was surprised. I was very surprised. And Brittany Brittany Baylog is our model right now. She's a model because she She does everything proper with her physique, her exercising, yoga, you name it, and she was never on any narcotic. So there's hope. There's hope. I think our operation is probably best, and the reason it does because we don't divide the duodenum. Reason when you divide any organ, any tissue, you separate them. You cut the nerves. You cut the microcirculation. You cut the in the duodenum. There's a what we call a neuroendocrine system. There's a lot of stuff in there. We don't know. We don't have all the answers for what the duodenum does. We don't have an answer. Not in the book. Not in the journal. Nothing. We still have to learn more about the duodenum. When you cut it or you divide it or you remove it, you're doing something really drastic. So they gotta be very careful with that. That has to be very careful. The so-called duodenal anteriorization was done first in Nigeria, way back in the 40s, maybe I think in the 50s. They had about 12 cases, but there's no follow-up. There was one case in Japan that they're basing it on now. One case that was done in 2008, that was published in 2008, but there's no follow-up on that case. And people are using that. And I think maybe there's something, maybe they have to be careful with that. Our case, we've done it I've done this in 1978. I didn't do anastomosis in the beginning. I only did 7 when the patient didn't do well with what I did, with the so-called strong and derotation completely. I had to go back and I have to do the anastomosis, and that worked. All my patients are doing well. Everyone I did, they have no issues. Now, am I lucky?
Can I ask you a question?
Yes.
So some patients are asking, and I don't know, because the EDS patients are concerned, and I got a question from Dr. Oh God, there's my brain not working. Dr. Kim,
Okay, yeah.
who does a lot of the
I know
EDS
Dr. Kim.
patients.
Yeah.
And he asked if a staple had to be used, or you had to use the stapler because of concern with just the metal. And some patients have metal allergy, and I know it's only one staple or whatever, but could you do it another way instead of using the stapler?
Oh yeah, definitely. Because when I originally did it, I did it open, and Dr. Stevenson preferred to do it open sometimes.
Okay.
Open anastomosis. We just put some stitches on the back of the jejunum and ilium, of the jejunum and duodenum, and then we open on each side, and then we suture it like a normal anastomosis. That's probably, if you are a skillful surgeon, the procedure will take you about 10-15 minutes to do that. For the staple, it only takes 5 seconds.
Right.
Stapler.
Okay.
So there's no difference. But otherwise, an open anastomosis is easy. I can teach anybody how to do that very easily.
Well, I'm sure most people know how to do it. It's just putting it in the, in the right spot.
Yeah, the right spot. Yes, correct. Yeah.
Okay. So I guess most people are here to learn a lot about your plan to go to the Philippines.
Yeah. Yes. The Philippines, I have identified three medical centers that are willing to tackle this situation, and I have one children's hospital in Manila, and another private hospital in Manila, and another private hospital in the middle of the Big Island. And in Manila, you of course land in the Manila airport. In the middle of the Big Island, Luzon, you land in what we call Clark Airport, like in the middle. There's a brand new airport in there. And so they're willing to pick the patient from where they are and bring them to a Airbnb. And I tell you, I was so surprised that including my airfare, my hotel, and the whole hospital 2 weeks in the hospital and 1 week in Airbnb, because we want you to be in the area for 1 month after the operation to make sure you're okay, that you don't have to go back to the hospital. So you can be in the hospital from a period of 10 days to 2 weeks, because that's the average, 10 days to 2 weeks. That includes OR, all the doctors and the fees, and then the Airbnb, including my airfare if I'm still there. Once I'm not there anymore, that's going to go down, because if they're trained, I don't have to be there anymore. So the current price is $20,000 for the whole thing. $20,000, because when a patient from Canada went to Virginia, she said she was $48,000 she paid cash for the service. $48,000. If you come to the Philippines, $20,000 will give you a 2-week hospital stay or longer, if you need it. 1 month in a 1-bedroom Airbnb with amenities, my airfare and my hotel, and a donation to the World Surgical Foundation. That's it. $20,000.
So would that be the same if you had more than one patient there at the same time, or is that?
Well, we will have to negotiate that, obviously.
Okay.
Yeah.
Okay.
If there are more than one patient, we'll negotiate that, and up to them to donate to the foundation whatever is left,
Right.
or if they have money. If they don't have much money, we'll negotiate that.
He's very good at negotiating, and the main thing is getting him there and keeping him there, because for the first, at least, and some people want him there just because if you're a revision or somebody tricky,
Yeah, right.
you definitely want him there. I know a lot of people have wanted him there in the past, especially if they've got complications, and hopefully he can work out a scenario where he can find some other surgeons that are able to do like they have over in Spain and even in Germany, where you can go for like the full package and have your nutcracker taken care of and your mouths, because he can train somebody to do mouth surgery as well, and find somebody who can do nutcracker surgery, because those guys they're not low class surgeons. They're highly skilled surgeons that are top of the class. And they also, when he sends his mission guys over there, they learn other stuff from the surgeons who go over on missions too. So I'm sorry, I didn't mean to butt in, but
no, that's good. I think what you're saying is the right thing, because the people I've chosen are skillful surgeons. I already know that from working with them. I worked with them before. At least 2 of them. They just send me their picture. Two of the guys they send me their smiling picture so I can put it in Facebook once I get time. Right. But I'm looking for the other guy that's supposed to. I have a lot of volunteers now. I have a plastic surgeon who is also a general surgeon. I have many people who are skillful surgeons who can do this. It's not difficult. It's not difficult because if you do it right, even when you do it open without stapling and everything, it will take about an hour and a half to 2 hours, no more than 2 hours for the procedure.